July 1945. The air inside the hospital is heavy with dust and antiseptic. Wooden window frames are splintered. Paper charts lie scattered across the floor, pressed down by falling ash from a raid that ended only minutes earlier. Outside, the distant thud of aircraft engines fades toward the sea. Inside the ward, Japanese nurses move quietly between rows of wounded. Their uniforms are smudged with soot. Water is scarce. Bandages are reused. The sound of breathing, uneven, strained, fills the room where electric lights no longer work. Then boots enter the corridor. Not hurried, not shouted. American soldiers step through the broken doorway, followed by U.S. Army medics carrying medical kits instead of weapons. They do not speak at first. They set down their gear. One soldier lifts debris from the floor. Another begins wiping blood from a metal bed frame. Buckets are filled. Windows are open for air. The nurses stop. They watch. What they were taught to expect does not match what is happening in front of them. This moment did not emerge from chance or sentiment. It was the result of years of doctrine, training, and a war that had reached its final, devastating phase. By the summer of 1945, the war in the Pacific had entered its most destructive phase. What had begun in December 1941 with sudden naval strikes and rapid territorial expansion had become a grinding campaign of attrition, fought across oceans, islands, and skies. The balance of power had shifted decisively. American industrial capacity, logistics, and manpower were now overwhelming the Japanese war effort from multiple directions. Strategic bombing had become central to this final stage. Beginning in 1944, U.S. Army Air Forces shifted from high-altitude precision bombing to low-altitude incendiary raids against Japanese cities. The change was driven by weather conditions, jet streams over Japan, and the effectiveness of firebombing against wooden urban structures. Tokyo, Osaka, Kobe, Nagoya, entire districts were reduced to ash within hours. Hospitals, despite markings and intentions to protect them, were often overwhelmed by blast damage, fire spread, or proximity to industrial targets. Japanese medical infrastructure was already strained before these raids intensified. Years of blockade had restricted medical supplies. Antibiotics, such as penicillin, were scarce. Electricity failures were common. Trained staff had been drafted or killed. Nurses, many of them young women trained under accelerated wartime programs, were expected to work long shifts under bombardment, often sleeping inside hospital buildings to ensure continuity of care. Imperial Japanese wartime doctrine emphasized endurance and sacrifice. Medical personnel were taught to preserve strength for soldiers deemed recoverable. Civilians and severely wounded patients were frequently triaged with grim efficiency. At the same time, military propaganda portrayed Allied forces as brutal, undisciplined, and vengeful, particularly toward women. Stories of mistreatment circulated widely, reinforced by official warnings and whispered fear. By contrast, American military planning placed medical services directly behind combat operations. The U.S. Army Medical Corps had expanded dramatically since 1941, drawing on civilian hospital standards, public health science, and lessons learned from earlier conflicts. Disease prevention, sanitation, and post-raid medical response were considered as strategically important as firepower. As American forces moved closer to the Japanese home islands, their medical units followed, into newly captured territory, into ruined towns, and eventually into spaces once thought unreachable. That convergence between devastation and doctrine set the conditions for encounters that neither side had anticipated. The U.S. Army Medical Corps that entered the Pacific in 1944 to 1945 was the product of rapid expansion and deliberate planning. From fewer than 1,000 physicians before the war, the Corps had grown to more than 50,000 medical officers, supported by nurses, orderlies, engineers, and sanitation units. Their mission extended far beyond treating battlefield wounds. It included epidemic control, water purification, waste disposal, and the stabilization of civilian health environments in war zones. This approach was shaped by hard experience. Early campaigns in the tropics had shown that disease could incapacitate more troops than enemy fire. Malaria, dysentery, dengue fever, and typhus were constant threats. As a result, American commanders treated cleanliness not as a courtesy, but as a military necessity. Orders emphasized that any occupied or assisted medical facility, enemy or civilian, had to be cleaned, ventilated, and supplied to prevent outbreaks that could spread to troops and populations alike. Medical personnel were trained accordingly. Field manuals instructed medics to assume responsibility for sanitation wherever they operated, regardless of nationality. Hospitals encountered after combat were assessed for contamination risks. Blood, debris, and stagnant water were to be removed immediately. Bedding was to be cleaned or destroyed. These procedures were applied in Europe and the Pacific alike, from liberated French towns to island field hospitals in the Philippines. In the Pacific theater, this doctrine intersected with a unique cultural divide. Japanese medical staff operated under a system deeply integrated with military hierarchy and imperial ideology. Nurses were trained to defer to authority, endure hardship without complaint, and maintain strict separation from the enemy. Direct cooperation with opposing forces was rarely imagined, let alone encouraged. American medics, by contrast, often encountered civilians and enemy wounded as part of standard operations. International conventions, while unevenly applied across the war, still shaped official conduct. Treating enemy wounded, preventing civilian epidemics, and stabilizing hospitals were considered part of post-combat responsibility, particularly in areas expected to come under prolonged control or occupation. By early 1945, these practices were already visible in Okinawa, Saipan, and Guam. U.S. medical units cleaned captured Japanese aid stations, treated wounded soldiers alongside civilians, and reorganized damaged facilities to manage mass casualties after bombardment. Reports from these operations circulated within military channels, reinforcing protocols rather than questioning them. When American soldiers and medics stepped into damaged Japanese hospital wards in the final months of the war, they were not acting on impulse or sentiment. They were following a system built for total war, one that recognized that survival, order, and health were inseparable from victory. Those principles would soon be tested not in manuals, but face to face with the people they had been taught were their enemies. By 1945, Japanese nurses stood at the intersection of exhaustion and expectation. Many had entered service as teenagers, trained rapidly as the war consumed experienced staff. Their daily reality was shaped by shortages of medicine, food, clean water, and time. During air raids, they worked through darkness, guided by memory rather than light, tending to patients while buildings shook around them. They had also been conditioned by years of instruction that framed the enemy as ruthless. American soldiers were described in training lectures and civil defense briefings as violent occupiers, indifferent to Japanese suffering. Nurses were warned to expect humiliation or worse if captured. These warnings were reinforced by isolation. Few had direct contact with Allied forces. Information flowed one way, filtered and controlled. When bombing raids struck urban areas, hospitals often became accidental shelters. Civilians crowded corridors. Soldiers were carried in from nearby barracks. The distinction between military and non-military patients blurred under the pressure of mass injury. Nurses triaged quickly, often making decisions that weighed survival against scarce resources. In that environment, the arrival of American soldiers inside a damaged ward carried a psychological weight that went beyond fear. It challenged assumptions built over years. The shock was not simply that the Americans entered. It was what they did once inside. Lifting debris, cleaning surfaces, restoring order without command or confrontation. Japanese wartime culture placed heavy emphasis on discipline, hierarchy, and ritual. Cleanliness was valued, but under conditions of bombing and deprivation, maintaining it had become nearly impossible. Assistance from the enemy was inconceivable within the moral framework taught during the war. American conduct disrupted that framework. The act of cleaning, a task associated with care rather than control, cut across expectations of domination or punishment. It created a moment of dissonance, where ideology failed to explain observed behavior. This dissonance did not immediately produce trust, but it produced pause. Silence replaced panic. Observation replaced fear. That pause opened space for something else to be revealed, not intention, but structure. The deeper reasons behind those actions lay not in emotion, but in systems designed long before these two groups ever met. For American forces, sanitation in medical spaces was not symbolic. It was tactical. Combat units in the Pacific operated at the edge of logistical reach, where a single outbreak of disease could reduce fighting strength as effectively as enemy action. Medical officers were trained to assume that any contaminated space, regardless of who occupied it, posed a threat to operational stability. Bombed hospital wards were especially dangerous. Open wounds, stagnant water, decomposing debris, and human waste created ideal conditions for infection. American medics entering these environments applied procedures drilled into them through months of training. Floors were cleared to reduce contamination. Bed frames were scrubbed to prevent bloodborne transmission. Windows were opened to improve airflow and reduce airborne risk. These actions were often carried out by enlisted soldiers before formal treatment even began. Cleaning was the first medical intervention. It stabilized the environment so that care could continue, whether for civilians, enemy wounded, or Allied personnel brought in later. There was no grand announcement when these practices were carried out. No public relations campaign. Orders regarding sanitation and civilian health were embedded in operational directives and medical manuals. Commanders understood that occupying or assisting devastated areas required immediate stabilization. In places like Okinawa, where civilians were caught between advancing lines, U.S. military leadership instructed medical units to prevent humanitarian collapse. Reports emphasized reducing civilian mortality, not for optics, but to prevent chaos, resistance, and long-term instability. This approach extended to Japanese medical facilities encountered after bombardment. Cleaning wards was not framed as kindness. It was framed as responsibility. Leadership expected medics to act decisively, efficiently, and without regard for the nationality of those affected. What struck Japanese nurses was not what was said. Often little was spoken, but what was done. The absence of force, the lack of raised voices, and the focus on routine tasks contrasted sharply with expectations of conquest. There was no attempt to erase hierarchy or impose familiarity. Americans did not instruct Japanese nurses on how to behave. They worked alongside them briefly, then stepped back. The message was conveyed through action alone. That combination, tactical necessity, quiet leadership, and restrained conduct, created a moment where the moral boundaries of the war shifted, not through declarations, but through practice. And it was in the aftermath of a bombing raid, amid broken glass and blood-stained floors, that this shift reached its most visible point. August 10th, 1945. The city lies in smoldering ruins. A recent bombing raid has left entire blocks flattened, with streets choked by debris. Smoke rises in columns, curling over twisted metal and shattered wood. The hospital at the city's edge stands battered but intact, a skeletal structure with shattered windows and cracked walls. Inside, the ward is chaotic. Patients lie where they fell. Blood seeps into wooden floors. Medical supplies are stretched thin. Japanese nurses move from bed to bed, their faces pale under the dim light filtering through broken glass. The air smells of antiseptic, dust, and iron. Then, from the main corridor, boots click on splintered flooring. U.S. Army medics enter, carrying clean sheets, scrub brushes, and buckets of water. Soldiers follow behind them, some assisting with debris, others preparing stretchers. There is no hesitation, no loud orders, only methodical action. The nurses stop in their tracks. Their training had prepared them for many scenarios, but not this. They had expected detachment, threat, perhaps even hostility. Instead, the Americans begin clearing floors, wiping down beds, and setting up clean linen. A metal tray of surgical instruments is disinfected and organized with meticulous care. A young nurse leans against a wall, her hand pressed to her mouth. Another kneels by a bed, watching as a soldier gently removes shards of wood from the frame, setting them aside. The sound of scrubbing fills the ward, rhythmic, deliberate, almost hypnotic against the background of distant sirens and groaning timbers. It is a turning point not for weapons or strategy, but for perception. The nurses realize that the Americans are not there to punish or dominate. They are there to restore order, to prevent further suffering. The act of cleaning is itself a statement, a disciplined, deliberate, and humane intervention in a space defined by destruction. And in that moment, the boundary between enemy and caregiver blurs, leaving only the shared weight of exhaustion, fear, and responsibility. The work continues for hours. Sunlight shifts through the broken windows, casting patterns of shadow across the ward. The American soldiers and medics move efficiently, washing floors, scrubbing bed frames, and arranging clean bedding. Every action is precise, executed with the quiet focus of men trained to respond to chaos without hesitation. Japanese nurses assist where they can, initially unsure, then gradually adapting. Some carry buckets, others hand over brushes, their movements tentative but increasingly coordinated. No words are exchanged beyond necessary instructions. The language barrier exists, but it does not impede the shared objective, restoring the ward to functionality. Outside, the city remains a landscape of ruin. Fires smolder in abandoned homes. The distant wail of sirens signals further emergencies. Yet within the hospital, there is a fragile order emerging, a controlled environment amid devastation. Patients, sensing the calm and efficiency, begin to relax slightly. Children clutch clean blankets. Wounded soldiers lie with less tension in their limbs. The act of cleaning becomes a silent reassurance. For the Japanese nurses, disbelief lingers. The soldiers had entered a space where fear and despair dominated. They expected aggression or neglect, as taught in propaganda and reinforced by years of isolation. Instead, they found care, an ordered, systematic, and purposeful intervention. Shock transforms into cautious observation. The human capacity for discipline and compassion, even in wartime, becomes undeniable. By the late afternoon, the ward is transformed. Bloodied floors are scrubbed clean. Broken beds are stabilized. Fresh linen is laid across stretchers. The nurses, exhausted but alert, realize the ward can now function properly, that patients can receive treatment under safer and more sanitary conditions. This transformation, carried out in silence and without ceremony, marks a subtle but profound shift in the psychological landscape of the war. It is here, amid scrubbed floors and orderly beds, that the climax of this episode is reached. Not through firepower or surrender, but through labor, discipline, and unexpected humanity, a human act capable of reshaping perceptions amid total war. In the weeks following the ward cleaning, reports from U.S. Army medical units documented the effects of these interventions. Hospitals once described as unsalvageable began functioning at full or near full capacity. Mortality rates from infection and disease dropped significantly in areas where American medical teams applied systematic sanitation, even when supplies remained limited. Observers noted that both military and civilian patients receive care more efficiently, reducing the burden on exhausted Japanese staff. For Japanese nurses, the experience left a lasting impression. Diaries and post-war memoirs recount a mix of shock, disbelief, and cautious respect. Witnessing enemy soldiers perform such disciplined and methodical care, without coercion, without insult, challenged long-held assumptions instilled by wartime education and propaganda. Nurses described the Americans' work as precise, efficient, and remarkably quiet, often emphasizing that the soldiers treated the environment with more care than many local staff could under extreme duress. The Japanese Ministry of Health, as well as local hospital administrations, began to recognize the practical benefits of these methods. Where possible, they adopted similar sanitation and organizational procedures once facilities returned to Japanese control. Although these changes were imposed out of necessity, they introduced practices previously uncommon under the extreme conditions of late-war shortages. Infection control, waste management, and structured patient care gained renewed emphasis, particularly in cities recovering from firebombing. American commanders documented these interventions not for propaganda, but for operational evaluation. After-action reports highlighted that even brief periods of ward stabilization significantly reduced disease transmission, protected combat readiness, and provided immediate humanitarian benefits. Medics were encouraged to replicate these practices across the Pacific theater, including Okinawa, the Philippines, and later in occupied Japan after surrender. The immediate aftermath extended beyond statistics and operational efficiency. Psychological shifts began to emerge among Japanese medical personnel. The act of Americans cleaning wards, though brief and practical, introduced an element of cognitive dissonance. Nurses, conditioned to expect hostility, were confronted with meticulous care and respect for human life. It was a quiet lesson in discipline, ethics, and shared humanity, one that would ripple into post-war perspectives on medical ethics and enemy engagement. As the weeks turned into months, the impact of these interventions extended beyond individual hospitals. Japanese civilians and medical staff began to recount experiences of American soldiers treating both patients and infrastructure with care. Stories circulated quietly. Diaries, letters, and post-war interviews preserve accounts of nurses observing soldiers scrub floors, repair beds, and organize supplies after bombing raids. For many, these acts contrasted sharply with the image of a ruthless enemy cultivated through years of wartime propaganda. The operational benefits were evident. Hospitals that had been non-functional due to structural damage, infection risk, or disorganization regained capacity to serve large numbers of patients. Mortality and morbidity rates decreased, not through combat, but through methodical hygiene and attention to detail. Field manuals circulated by the Army Medical Corps highlighted these interventions as exemplary models of wartime medical practice. Beyond immediate health outcomes, there was a subtle shift in psychological and cultural perception. Japanese nurses, who had witnessed the Americans' quiet, disciplined care, began integrating similar methods into daily routines. Infection control, patient organization, and sanitation procedures became more systematized, influenced indirectly by the observation of American practices. The encounter challenged assumptions about enemy intent and highlighted the universality of medical responsibility even in war. In occupied territories following Japan's surrender, these experiences shaped early reconstruction efforts. American medical personnel assisted in training Japanese nurses, emphasizing sanitation, triage, and organized patient care. Institutions like the Japanese Red Cross incorporated lessons learned from these direct interactions, improving hospital management standards nationwide. The enduring effect was a blend of cultural and operational transformation, a recognition that meticulous care, discipline, and adherence to medical ethics could transcend national and wartime boundaries. Ultimately, these actions, quiet, unheralded, and methodical, serve as a small yet profound human intervention. They demonstrated that even amidst total war, acts grounded in discipline, respect, and professional responsibility could alter both immediate outcomes and long-term perceptions. From the scorched hospital wards of 1945 emerged lessons that shaped post-war medical practice, civilian recovery, and the understanding of shared humanity under extreme circumstances. The image of American soldiers quietly cleaning a bombed hospital ward in 1945 remains striking not because of heroism in battle, but because of the discipline, precision, and humanity it represented. In a war defined by destruction and ideological enmity, these acts stood apart, demonstrating that even amid the worst violence, professional responsibility and respect for life could persist. For Japanese nurses who witnessed it, The experience challenged long-held beliefs and reshaped perceptions of the enemy. Shock gave way to cautious understanding, and disbelief gave way to recognition of order, care, and shared human duty. This moment also illustrates the broader significance of medical and logistical planning in modern warfare. Victory is not measured solely in territory gained or bombs dropped, but in the capacity to preserve life, prevent disease, and stabilize society in the wake of destruction. The U.S. Army Medical Corps' approach exemplified how systemic preparation could turn chaos into manageable environments, safeguarding both combat forces and civilian populations. On a human level, the ward cleaning reflected a universal principle. Action, grounded in ethical and practical responsibility, can transcend ideology and conflict. The soldiers' scrubbing of floors and organization of beds became more than routine tasks. They became statements about care, discipline, and the continuity of civilization even amid devastation. As history evaluates the final months of the Pacific War, this episode reminds us that small, deliberate actions, quiet, methodical, and seemingly ordinary, can leave enduring impressions. They reveal the possibility of shared humanity amidst war, the transformative power of professional ethics, and the ways ordinary tasks can become extraordinary when set against the backdrop of global conflict.